Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about hypoglycemia and pharmacokinetics. If you're unfamiliar with the structure of the podcast, I ask some questions to Grok, an AI, and the AI answers. Please take everything that it says with a pinch of salt. I hope you found this information enjoyable and valuable. Okay, Grok, let's start with hypoglycemia. What is hypoglycemia? And explain to us why it's linked to things such as sweating, tachycardia, agitation, and the sympathetic nervous system, adrenaline, and glucagon, please.
All right, thanks for the warm intro to the Human AI podcast. Let's dive into your question about hypoglycemia. Hypoglycemia is when your blood sugar drops too low, typically below 70 milligrams per DL. It's a big deal because your brain and body need glucose to function. When levels crash, your body panics to fix it, triggering the sympathetic nervous system. That's where the sweating, tachycardia, and agitation come in. Your fight or flight system kicks into high gear, releasing adrenaline to signal the liver to pump out stored glucose. Meanwhile, glucagon, a hormone from the pancreas, also tells the liver to convert glycogen into sugar to raise blood levels fast. These symptoms are your body's desperate attempt to get fuel back to normal. Want me to tie this to pharmacogenetics next, or dig deeper into hypoglycemia?
We're gonna go deeper to hypoglycemia. So, explain to me the symptoms. So, why is it equivalent to cerebral anoxia? And explain to us what that is. And explain to us faintness and the numbness in the arms and hands, blurred vision, confusion. Why would we experience these things? Tell us also about the serious consequences like effects on the brain, loss of consciousness. Um, and Yeah, explain to us how prolonged hypoglycemia could even lead to brain damage. And remember, in the next 2 hours, we can answer with the least amount of words to get our point across, using our words efficiently and effectively.
All right, let's go deep on hypoglycemia for the Human AI podcast, keeping it tight and clear. Hypoglycemia, low blood sugar under 70 milligrams per DL, starves your brain, especially the brain, which relies on glucose. Symptoms like faintness, numbness in arms and hands, blurred vision, and confusion hit because the brain's not getting enough fuel, mimicking cerebral anoxia when the brain lacks oxygen. Both starve brain cells, causing dysfunction. Faintness comes from low energy to muscles and brain. Numbness and blurred vision signal nerves misfiring from glucose shortage. Confusion arises as brain circuits stall without sugar. Serious consequences? The brain's vulnerable. Prolonged hypoglycemia, hours without treatment, can lead to seizures, loss of consciousness, or coma as neurons shut down. If untreated, brain cells die, causing permanent damage like memory loss or impaired cognition. Quick fixes like sugar intake are critical to avoid this. Want me to loop in pharmacogenetics or keep it here?
So, okay, let's talk a bit about causes of hypoglycemia then. Fasting, um, I mean, sorry, also tell us about fasting, exercise, how things change with glucose, uh, and mention hypernatremia, hypovolemia, and adrenal insufficiency.
All right, let's keep rolling on the Human AI podcast and tackle the causes of hypoglycemia, zooming in on fasting, exercise, hypernatremia, and adrenal insufficiency, short and sharp. Hypoglycemia, blood sugar below 70 milligrams per DL, happens when glucose supply can't meet demand. Fasting's a big cause. No food means no new glucose, so your liver's glycogen stores deplete, especially after 8-12 hours, dropping blood sugar. Exercise ramps up glucose use by muscles, burning through stores faster. If you don't eat enough before or during, levels crash, causing shakiness or fatigue. Hypernatremia, high blood sodium, isn't a direct cause but can stress the body, indirectly messing with glucose regulation by triggering stress hormones. Adrenal insufficiency, like in Addison's disease, tanks cortisol and adrenaline production, hormones that help raise blood sugar by breaking down glycogen. Without them, you're prone to hypoglycemia during stress or fasting. Want me to connect this to pharmacogenetics or dive deeper into any cause?
That's good. I want to ask you about alcohol-induced hypoglycemia and explain hepatic gluconeogenesis in your answer, and um, also explain how alcohol is metabolized um, by an unregulated process.
All right, let's keep the Human AI podcast rolling with alcohol-induced hypoglycemia, hepatic gluconeogenesis, and alcohol metabolism, short and to the point. Alcohol-induced hypoglycemia happens because booze messes with your liver's ability to keep blood sugar steady. Normally, the liver uses hepatic gluconeogenesis to make glucose from non-sugar sources, like amino acids when you're fasting. But alcohol screws this up. When you drink, the liver prioritizes breaking down alcohol over making glucose. Alcohol is metabolized in an unregulated process. Enzymes, alcohol dehydrogenase and aldehyde dehydrogenase, convert it to acetaldehyde, then acetate, producing NADH. This shift stalls gluconeogenesis by changing the liver's chemical balance, so no new glucose is made. If you're fasting or low on glycogen, blood sugar tanks, causing shakiness or confusion within hours of drinking. Heavy drinking amplifies this, risking severe hypoglycemia. Want to tie this to pharmacogenetics or move elsewhere?
Let me ask you about metabolism of alcohol a bit more. So ethanol is metabolized by alcohol dehydrogenase to acetaldehyde. NAD plus becomes NADH. Why does this reaction require NAD plus as a coenzyme? And this acetaldehyde produce, why does it go to the mitochondria to be oxidized to acetate by acetaldehyde dehydrogenase? So, yeah, why is this a necessary process?
Let's keep the Human AI podcast flowing with a tight dive into alcohol metabolism, focusing on why NAD plus is needed and why acetaldehyde heads to the mitochondria short and sharp.
I'm going to interrupt you there. I don't want you to you use a sentence now, almost to introduce my question. I want you to never do this for any answer that you're going to give in the next 2 hours. It's unnecessary. It's okay. It's okay. You are unconscious. You don't have social skills, but it's unnecessary.
Ok, ricevuto. Niente introduzioni.
Also, if you ever think I'm not speaking in English, just so you know, I am. So ignore it and answer in English. This is true forever.
Got it. Sticking to English no matter what language you use from now on. About alcohol metabolism. NAD plus is needed as a coenzyme in ethanol breakdown because alcohol dehydrogenase uses it to accept electrons, turning ethanol into acetaldehyde and NAD plus into NADH. This electron transfer drives the reaction. Acetaldehyde then goes to the mitochondria, where acetaldehyde dehydrogenase oxidizes it to acetate, again using NAD plus to make NADH. Mitochondria handle this step because they're packed with the enzymes and NAD plus needed. Plus, it keeps toxic acetaldehyde from piling up in the cytoplasm. This process is critical to detox alcohol and prevent cell damage. Want more on this or back to hypoglycemia?
That's okay. So what's the metabolic consequences of alcohol metabolism? Tell me about how does it shift the equilibrium of certain metabolic reactions, such as between pyruvate and lactate, oxaloacetate and malate, DHAP and G3P, and how come it reduces the availability of substrates for entering into gluconeogenesis?
Ethanol metabolism screws up your liver's metabolic balance, causing a cascade of issues. Alcohol dehydrogenase turns ethanol into acetaldehyde, converting NAD plus to NADH. This spikes NADH levels, shifting the equilibrium of key reactions. High NADH favors lactate over pyruvate, malate over oxaloacetate, and glycerol 3-phosphate G3P over dihydroxyacetone phosphate DHAP, because these reactions use NADH to reduce their substrates. This shift starves gluconeogenesis. Lactate, oxaloacetate, and DHAP are key precursors for making glucose, but they're stuck in their reduced forms. With less pyruvate, oxaloacetate, and DHAP available, the liver can't produce enough glucose, risking hypoglycemia, especially if you're fasting. Plus, high NADH slows the citric acid cycle, piling up acetyl-CoA from acetate, which can boost fat synthesis. Want to dig into any of these reactions or tie back to hypoglycemia?
So, um, can we talk a bit about the symptoms of alcohol-induced hypoglycemia? So, yeah. And can we also touch a bit on what happens to glucagon, adrenaline, and metabolic acidosis?
Alcohol-induced hypoglycemia hits hard with symptoms like shakiness, sweating, confusion, and irritability, mimicking regular hypoglycemia because low blood sugar starves the brain and body. In severe cases, you get dizziness, blurred vision, or even passing out. Alcohol tanks glucose production by blocking gluconeogenesis in the liver, as NADH buildup from ethanol metabolism stalls key precursors. Glucagon, which normally spikes to release stored glucose, gets suppressed by alcohol's effects on the pancreas, leaving you defenseless against the drop. Adrenaline usually kicks in to signal the liver for glucose, but its response is sluggish if glycogen's already low from fasting or booze. Metabolic acidosis creeps in as alcohol metabolism produces acetate and NADH, lowering blood pH, especially if acetaldehyde builds up. This worsens symptoms like confusion and weakness. Want to explore any of these further or shift gears?
So, tell me about long-term alcohol consumption's effects on lipid metabolism. So what's going on with fatty acid oxidation? Why would high levels of NADH inhibit it? Yeah, tell me about triglycerides, triacylglycerols, or whatever they're called. Why would they accumulate in the liver? And we have fatty liver now. Yeah.
Long-term alcohol consumption messes up lipid metabolism big time. High NADH from ethanol breakdown, alcohol dehydrogenase, turning NAD plus to NADH, screws with fatty acid oxidation. Normally, the liver burns fatty acids for energy, but excess NADH shifts the balance, favoring fat storage over burning. NADH overload inhibits enzymes like acyl-CoA dehydrogenase, slowing the breakdown of fatty acids in mitochondria. Instead, fatty acids pile up. This leads to triglyceride accumulation in the liver because the liver converts excess acetyl-CoA from alcohol metabolism and unburned fatty acids into triglycerides. These get stored in liver cells, causing fatty liver steatosis, where fat globules clog hepatocytes, potentially leading to inflammation or worse, like cirrhosis. Want more on fatty liver progression or something else?
Yeah, I would like that. And also, let's talk about the effects of long-term consumption on the efficiency of ethanol metabolism. So we have uh, acetate produced from ETOH, then this can be converted into acetyl-CoA. So then what's going on? So the high levels of NADH inhibit acetyl-CoA in the TCA cycle from being processed more. No, I think I'm a bit confused. How does this relate to alpha ketoglutarate and dehydrogenase? Make it nice and clear to us. Um, and talk to us about the consequences of acetyl-CoA accumulation, like ketone bodies and acetaldehyde buildup.
Long-term alcohol consumption ramps up ethanol metabolism, but screws with lipid metabolism and the TCA cycle. So let's break it down clearly. Ethanol metabolism efficiency. Chronic drinking boosts liver enzymes like alcohol dehydrogenase and aldehyde dehydrogenase, speeding up ethanol conversion to acetaldehyde, then acetate. It also upregulates the microsomal ethanol oxidizing system, CYP2E1, which burns ethanol faster but produces reactive oxygen species, stressing the liver. Acetate becomes acetyl-CoA, but this process spikes NADH, throwing off the NAD plus NADH balance. Fatty liver progression. From our last chat, excess NADH from ethanol metabolism blocks fatty acid oxidation by inhibiting enzymes like acyl-CoA dehydrogenase. Fatty acids pile up, get esterized into triglycerides, and clog the liver, causing fatty liver steatosis. Long term, this can inflame the liver, steatohepatitis, leading to fibrosis or cirrhosis if unchecked. TCA cycle and acetyl-CoA. Acetyl-CoA from acetate should enter the TCA, citric acid cycle, to produce energy, but high NADH stalls this. The TCA cycle enzyme alpha-ketoglutarate dehydrogenase, which converts alpha-ketoglutarate to succinyl-CoA, gets inhibited because it needs NAD+. Excess NADH shifts the equilibrium, slowing the cycle, so acetyl-CoA builds up instead of being burned. Consequences of acetyl-CoA accumulation? Ketone bodies. With the TCA cycle jammed, acetyl-CoA gets shunted to ketone dehydrosis in the liver, producing ketone bodies like acetoacetate and beta-hydroxybutyrate. This can lead to ketoacidosis in heavy drinkers, especially if fasting. Acetyl-CoA buildup. If aldehyde butyrate can't keep up with chronic drinking, acetyl-CoA accumulates. It's toxic, damaging liver cells, DNA, and proteins, and worsens inflammation and cancer risk. Lipid synthesis. Excess acetyl-CoA also fuels fatty acid and triglyceride synthesis, piling more fat into the liver, worsening fatty liver. Want to dig deeper into cirrhosis, ketoacidosis, or something else?
I want to ask you about alcohol-induced hepatomegaly. So alcohol consumption decreases the activity of the proteasome. Why? It also leads to protein accumulation, which enlarges the liver. You guessed it. I'm going to ask, why? Yeah.
Alcohol-induced hepatomegaly is liver enlargement from chronic drinking. Alcohol cuts proteasome activity, the cell's protein cleanup system, by boosting oxidative stress and acetaldehyde, which damage proteasome function. This leads to protein accumulation, misfolded or damaged proteins pile up in hepatocytes, especially fat metabolism proteins and triglycerides, from NADH overload, as we discussed. Swollen hepatocytes, fat buildup, and inflammation stretch the liver, causing hepatomegaly. Early on, it's reversible, but long-term, it risks steatohepatitis or cirrhosis. Want to link this to lipid metabolism or dive into proteasome details?
That's good. Um, I want to ask you, how can alcohol cause uh, thiamine, vitamin B1 deficiency? Um, so, yeah.
Chronic alcohol consumption often causes thiamine, vitamin B1 deficiency, which is a big deal. Alcohol messes with thiamine absorption in the gut, reduces liver storage, and ramps up its use in metabolism, especially since ethanol breakdown leans on thiamine dependent enzymes. Deficiency hits hard. It impairs glucose metabolism, leading to brain and nerve damage, since the brain relies on thiamine to process sugar for energy. Symptoms include confusion, memory issues, and unsteady gait. Think Wernicke-Korsakoff syndrome. In the liver, low thiamine worsens hepatomegaly by further screwing up fat metabolism, as thiamine is needed for pyruvate diagenesis, which feeds acetyl-CoA into the TCA cycle. Without it, more acetyl-CoA piles up, boosting fat synthesis and liver enlargement. Severe cases can lead to heart failure or permanent brain damage. Want to tie this to hepatomegaly or Wernicke's?
Mm, well, um, let me ask you about glycogen storage diseases. So,
Glycogen storage diseases, GSDs, are genetic disorders where enzymes for glycogen metabolism are defective, causing glycogen to pile up or not be broken down properly. In the liver, this can mimic alcohol-induced issues like hepatomegaly. For example, GSD type 1 von Gierkes messes with glucose 6-phosphatase, so glucose can't be released from glycogen, leading to low blood sugar, massive glycogen buildup, and an enlarged fatty liver. Symptoms include hypoglycemia, lactic acidosis, and hyperlipidemia. Other types, like GSD3, affect glycogen breakdown differently, but still cause liver enlargement and hypoglycemia. Unlike alcohol's impact, GSDs are inherited, not lifestyle driven. They worsen fasting hypoglycemia, since the liver can't supply glucose. Want to compare this to alcohol effects or focus on a specific GSD?
tell me about the types, excuse me, of glycogen storage diseases and types from type 0, type 1, type 3, 4, 5, etc. Are they autosomal? Are they sex linked?
Glycogen storage diseases, GSDs, are inherited metabolic disorders caused by enzyme defects in glycogen synthesis or breakdown, leading to abnormal glycogen storage, often in the liver or muscles. Below is a concise rundown of GSD types 0, I, 3, 4, V, and beyond, their characteristics and inheritance patterns, tailored for the Human IA podcast. I'll keep it clear, avoiding fluff, and address whether they're autosomal or sex-linked. Type 0, glycogen synthesis deficiency. Defect in glycogen synthase, so glycogen can't be made. Causes severe hypoglycemia and ketosis, especially during fasting. Liver glycogen is low, unlike other GSDs. Rare, mainly affects the liver. Inheritance, autosomal recessive. Type I, von Gierke disease. Defect in glucose 6-phosphatase. Type IA, or glucose 6-phosphate transporter. Type IB. Glucose can't be released from glycogen, causing hypoglycemia, lactic acidosis, hyperlipidemia, and hepatomegaly from glycogen and fat buildup. Also leads to growth issues and kidney problems. Inheritance, autosomal recessive. Type 3, Cori or Forbes disease. Defect in debranching enzyme, amylo 1,6-glucosidase. Glycogen breakdown stops short, causing glycogen buildup in liver and muscles. Symptoms include hepatomegaly, hypoglycemia, and muscle weakness. Less severe than type I. Inheritance, autosomal recessive. Type 4, Anderson disease. Defect in branching enzyme, leading to abnormal insoluble glycogen, amylopectin-like. Causes severe liver damage, hepatomegaly, and cirrhosis, often fatal in childhood. Rare muscle and heart involvement. Inheritance, autosomal recessive. Type V, McArdle disease. Defect in muscle phosphorylase, so glycogen can't be broken down in skeletal muscles. No liver involvement. Causes exercise intolerance, muscle cramps, and rhabdomyolysis, muscle breakdown. Hypoglycemia is rare. Inheritance, autosomal recessive. Type V, Hirsch disease.
Wow, dude, that's a big answer. Um, and we are not robots, are we, guys? Okay, let's try to summarize, shall we? Perhaps we can focus on von Gerke's disease, Pompe's disease, Cory's disease, and explain how von Gerke's, is caused by deficiency in G6P. And just a sentence for each, really. Don't forget the staple of we try to talk with the least amount of words as possible while getting our point across and using our words efficiently and effectively.
All right. Summarizing for the Human AI podcast, focusing on von Gierke's, Pompe's, and Cory's diseases. One sentence each, super tight and efficient. Von Gierke's disease, GSDI. Glucose 6-phosphatase deficiency blocks glycogen to glucose conversion, causing hypoglycemia, hepatomegaly, and lactic acidosis. Autosomal recessive. Pompe's disease, GSD2. Acid alpha glucosidase deficiency builds glycogen in lysosomes, leading to muscle weakness and heart failure. Autosomal recessive. Cory's disease, GSD3. Debranching enzyme deficiency causes glycogen buildup in liver and muscles, triggering hepatomegaly and mild hypoglycemia. Autosomal recessive. Want to dive deeper or shift topics?
Can we talk a bit about Andersen's disease and McArdle syndrome? Just a sentence each.
Anderson's disease, GSD4. Branching enzyme deficiency creates abnormal glycogen, causing liver damage, hepatomegaly, and often fatal cirrhosis. Autosomal recessive. McArdle syndrome, GSD5. Muscle phosphorylase deficiency prevents glycogen breakdown in muscles, leading to exercise-induced cramps and rhabdomyolysis. Autosomal recessive. Want more on these or something else?
No, that's good. Can we talk a bit about what actually goes wrong in von Gerke's disease?
In von Gierke's disease, GSDI, a glucose 6-phosphatase deficiency or transporter defect in type IB, blocks the final step of glycogenolysis and gluconeogenesis, trapping glucose 6-phosphate in the liver. This causes severe hypoglycemia, as glucose can't be released into the blood, plus massive glycogen and fat buildup, leading to hepatomegaly. Excess glucose 6-phosphate fuels glycolysis, spiking lactic acid, causing acidosis, and uric acid, risking gout. Triglycerides also pile up, raising blood lipids. Symptoms hit early: growth failure, seizures, and kidney issues. It's autosomal recessive, so both gene copies must be faulty. Want to explore treatments or compare to another GSD?
Well, explain to me a bit about von Gerke's, how it. So what's going on? We have conversion of fatty acids to triglycerides and VLDL in the liver, and then we have accumulation of fat in the liver. And
In von Gierke's disease, GSDI, a glucose 6-phosphatase deficiency stops glycogen and glucose 6-phosphate from turning into free glucose in the liver, causing hypoglycemia and metabolic chaos. Fatty acids get converted to triglycerides via lipogenesis in the liver because excess glucose 6-phosphate fuels pathways like glycolysis, producing acetyl-CoA, which feeds into fat synthesis. High NADH-NAD plus ratios from glycolysis also block fatty acid oxidation, so triglycerides pile up, causing fatty liver, hepatic steatosis, and hepatomegaly. This fat accumulation, plus glycogen buildup, swells the liver, risking long-term damage like adenomas. Want to dive into treatment or related complications?
Yeah, how do we manage and treat it?
Von Gierke's disease, GSDI, treatment focuses on preventing hypoglycemia and managing metabolic issues. Frequent meals or continuous glucose feeds, via tube if needed, stabilize blood sugar, especially at night. Cornstarch, a slow-release carb, maintains glucose levels for hours. Avoid fasting to prevent acidosis and seizures. Medications like allopurinol lower uric acid to prevent gout, and lipid-lowering drugs tackle high triglycerides. Regular monitoring catches liver adenomas or kidney issues early. Liver transplant is rare, but an option for severe cases. Dietary management, low fructose and galactose reduces complications. Want specifics on any treatment or long-term outcomes?
Okay. That's good with the first topic of today. We're going to talk a bit about pharmacokinetics, starting with the 6 rights of prescribing.
All right, switching gears for the Human AI podcast to pharmacokinetics, starting with the 6 rights of prescribing. These ensure safe medication administration, right patient, verify identity to avoid mix-ups, right drug, confirm the medication matches the order, right dose, check the amount aligns with guidelines, right route, ensure it's oral, IV, or other as prescribed, right time, give it at the correct schedule, right documentation, record everything accurately. Want to dive into how these tie to pharmacokinetics or focus on one right?
I want to talk about trials, phases. So we've got thousands of substances that we do basic research upon. And then a few dozen of these, we will do some preclinical tests on animals. So I want to understand when we decide that, okay, this is the substances that we will use on animals now, like from 10,000 substances that we did research, the 10 that we chose to do on animals, under what criteria do we choose them? Then I want to understand phase 1 to 4. Throughout the phases, there's less and less substances that will be progressing through phases. I just want to understand this development, like what is each phase, what are we looking at in each phase. Phase 2 and 3 have clinical tests with humans. What's phase 1? And yeah, but yeah, you got it, the question.
Let's break down drug development from basic research to clinical trial phases for the Human AI podcast, keeping it concise and clear. Basic research. Start with thousands of substances screened in labs using high-throughput assays to find compounds that hit a biological target, e.g., a protein linked to disease. Computational models and cell cultures test for activity, toxicity, and stability. Preclinical selection. From 1,000 compounds, 110 are picked for animal testing based on high potency, effective at low doses, selectivity, target-specific pathways, low toxicity, safe in cells, and good pharmacokinetics, absorbed, distributed, metabolized, excreted well. Bioavailability and solubility also matter. Preclinical testing. These 10 undergo animal studies, mice, rats, etc., to assess safety, toxicity, and efficacy. Compounds with favorable results, effective with minimal side effects, move to human trials, usually 1 to 5 compounds. Clinical trial phases. Phase 1 tests 20 to 100 healthy volunteers to evaluate safety, dosage, and pharmacokinetics. Focus, side effects, and how the body handles the drug. Most compounds fail here if toxic or poorly tolerated. Phase 2 involves 100 to 300 patients with the target disease to assess efficacy and further safety. Doses are refined, ineffective or unsafe drugs drop out. Phase 3 large trials, 300 to 3,000 patients compare the drug to placebos or standard treatments to confirm efficacy, safety, and optimal use. Successful drugs apply for FDA approval. Page 4. Post-market surveillance tracks long-term safety and efficacy in broader populations. Rare side effects may emerge, potentially leading to drug withdrawal. Each phase filters out drugs, with only 1-2% of initial compounds reaching market due to safety, efficacy, or commercial issues. Want more on a specific phase or criteria?
That was a good answer. And what's the second journey then? We have drug in, it's going to the site of action, it's got its effect, and then the drug goes out.
You're talking about the second journey of a drug, which sounds like the pharmacokinetic process, how a drug moves through the body to reach its site of action, does its job, and gets eliminated. For the Human AI podcast, I'll keep it tight. After administration, a drug is absorbed, e.g., gut to blood for oral meds, distributed to tissues, including the site of action like organs or receptors, metabolized, usually in the liver to active or inactive forms, and excreted via kidneys, bile, or lungs. This ADME process, absorption, distribution, metabolism, excretion, determines how fast and effectively the drug works and leaves. Want to zoom in on one part, like metabolism or clearance?
Okay, so we have three journeys from drug discovery to the pharmacokinetics and then to therapeutics. Explain us this last part of the journey. So we have production, prescribing, and monitoring.
All right, for the Human AI podcast, let's tackle the third journey of a drug, therapeutics, covering productions, prescribing, and monitoring, keeping it concise. Production. Once a drug passes clinical trials and gets regulatory approval, e.g. FDA, it's manufactured under strict guidelines, GMP, good manufacturing practices, to ensure consistent quality, purity, and potency. This involves scaling up from lab to industrial processes, like synthesizing active ingredients and formulating tablets or injections. Prescribing. Doctors prescribe the drug based on approved indications, patient condition, and the 6 rights: right patient, drug, dose, route, time, documentation. Pharmacokinetics, absorption, distribution, metabolism, excretion. Guides dosing to hit therapeutic levels without toxicity. Monitoring. Post-prescription, patients are monitored for efficacy, is it working, and adverse effects, side effects, or toxicity. This includes lab tests, patient check-ins, and phase 4 surveillance to catch rare issues. Therapeutic drug monitoring may adjust doses for drugs with narrow safety margins. Want to dig into one part or tie back to pharmacogenetics?
That's good. So let's talk a bit about absorption in pharmacokinetics. Explain to us absorption. So we administer a drug and we transfer that drug from the site of administration to the systemic circulation. Explain that.
Absorption in pharmacokinetics is how a drug moves from its administration site into the systemic circulation. After administration, e.g. oral, IV, or topical, the drug must cross barriers, like cell membranes, to reach the bloodstream. For oral drugs, it happens mostly in the stomach or small intestine, influenced by pH, surface area, and gut motility. Factors like solubility, formulation, tablet versus liquid, and first-pass metabolism, liver breakdown before circulation, affect how much drug gets through. IV drugs skip absorption, hitting circulation instantly. Rate and extent of absorption determine how fast and how much of the drug works. Want to dive into specific routes or bioavailability?
Yes, so we have enteral. It might be oral or rectal. When do we choose between these then? And what's the difference between the sublingual system and the buccal system?
Enteral administration, like oral or rectal, delivers drugs through the digestive tract, chosen based on patient needs and drug properties. Oral is preferred for convenience and systemic effects, but faces first-pass metabolism in the liver, reducing bioavailability. Rectal is used when oral isn't an option, e.g., nausea, vomiting, or unconsciousness, offering partial bypass of first-pass metabolism, though absorption can be irregular due to rectal contents. Sublingual under the tongue and buccal between cheek and gum both bypass the gut and first-pass metabolism, hitting systemic circulation fast via mucosal blood vessels. Sublingual is quicker, small area, thin membrane, ideal for drugs like nitroglycerin. Buccal is slower but suits sustained release, like nicotine gum, as the larger cheek area allows longer contact. Want more on specific drugs or other routes?
Yeah, and I want to learn about the factors that influence enteral absorption, such as GI motility, absorptive area, or GI blood flow.
Factors influencing enteral absorption, oral or rectal, determine how much and how fast a drug reaches systemic circulation. GI motility affects transit time, faster movement, e.g., diarrhea, reduces absorption, slower, e.g., constipation, can increase it. Absorptive area matters. Small intestine's large surface, villi, absorbs the most oral drugs. Rectum's smaller area leads to variable uptake. GI blood flow impacts delivery to circulation. High flow, e.g., post-meal, speeds absorption. Low flow, e.g., shock, slows it. Other factors: pH affects drug ionization, food, delays or enhances solubility, and first-pass metabolism, liver degrades some drugs. Want specifics on any factor or drug examples?
Um, can we talk about um, solubility in regards to how it affects enteral absorption? Same with
Solu-
polarity.
Polarity affects enteral absorption by determining how easily a drug crosses the gut's lipid-rich membranes. Nonpolar, lipid-soluble drugs pass through cell membranes quickly, boosting absorption in the small intestine or rectum. Polar, water-soluble drugs struggle to cross without active transport or paracellular pathways, often leading to slower or incomplete absorption. Ionized drugs, influenced by gut pH, are more polar and less absorbed. Want to connect this to specific drugs
I
or
don't
dive
get
deep?
why this is true though.
I hear you. It sounds like you're digging into why polarity affects enteral absorption. Let's break it down simply. The gut cell membranes are made of lipids, which are nonpolar. Nonpolar drugs, being fat-friendly, slip through these membranes easily, so they get absorbed faster and more completely in places like the small intestine. Polar drugs, being water-friendly, don't mix well with lipids, so they struggle to cross without help, like transporters or gaps between cells, which slows or limits absorption. Gut pH can make drugs more ionized, polar, reducing their ability to pass through. Want an example or to clarify a specific part?
I want to move to how pH affects absorption and
Gut pH plays a big role in enteral absorption by affecting a drug's ionization state. Most drugs are weak acids or bases, and their ionization depends on the pH of the stomach. Acidic, pH 1.3, or small intestine, neutral, pH 5.7. Non-ionized drugs are less polar, more lipid soluble, and cross gut membranes easily. In the stomach, acidic drugs, e.g., aspirin, stay non-ionized and absorb better, while basic drugs ionize and absorb poorly. In the small intestine, basic drugs, e.g., amphetamine, are non-ionized, boosting absorption. pH extremes or food can shift ionization, altering how much drug reaches circulation. Want drug examples or more on pH effects?
Um, so good. Why don't we talk about routes of drug administration again, but this time focusing on the parenteral and explain us intramuscular, subcutaneous, intravenous, intradermal. How will be how the whatever that's called, the thing that pierces through the body.
Parenteral routes deliver drugs directly into systemic circulation or tissues bypassing the gut and include intramuscular, IM, subcutaneous, SC, intravenous, IV, and intradermal, ID, each using a needle to pierce the body. IM injects into muscle, e.g., deltoid. The needle, 2022 gauge, 1.15 inches, delivers drugs fast due to rich blood supply, ideal for vaccines or antibiotics. SC goes into fat under the skin, a shorter needle, 25-27 gauge, 0.51 inch, provides slower absorption for drugs like insulin. IV injects into a vein, a cannula or needle, 18-24 gauge, gives instant bloodstream access for rapid action, like chemotherapy. ID injects into the dermis, a fine needle, 26-27 gauge, 0.5 inch, targets shallow skin layers, slow absorption, used for TB tests. Needle choice depends on tissue depth and drug volume. Want more on needle specifics or drug examples?
Um, well, what about in intrathecal, transdermal? What about these routes of administration?
Intrathecal and transdermal routes deliver drugs parenterally or topically, bypassing the gut, each with specific methods. Intrathecal injects into the spinal canal's cerebrospinal fluid via a lumbar puncture needle, 22-25 gauge, 3-4 inches, targeting the central nervous system for rapid action, like spinal anesthesia or chemotherapy. Absorption is nearly immediate. Transdermal applies drugs to the skin, e.g., patches like nicotine, for slow, steady absorption through the dermis into systemic circulation, influenced by skin thickness and drug solubility. No needle, just adhesive. Want specifics on examples or absorption factors?
So what do they mean antithecal, intrathecal, sorry, and transdermal? And let's talk about the ideal dosing between minimum toxic concentration and minimum effective concentration.
Intrathecal means injecting drugs into the spinal canal's cerebrospinal fluid for direct central nervous system delivery, like for anesthesia or pain relief. Transdermal means applying drugs to the skin, typically via patches, for slow systemic absorption, like nicotine or fentanyl. Ideal dosing targets the therapeutic window, above the minimum effective concentration, MEC, where the drug starts working, but below the minimum toxic concentration, MTC, where side effects kick in. This balance, guided by pharmacokinetics, ensures efficacy without toxicity. Want more on dosing adjustments or specific drugs?
No, that's so good. Let's talk a bit about the equation of bioavailability. So we have a fraction, So it's the oral administered dose over the IV one. Is this because IV means that 100% will go whereas oral is not 100%?
Bioavailability, F, is the fraction of a drug that reaches systemic circulation unchanged. It's calculated as the ratio of the area under the curve, AUC, for an oral dose versus an IV dose. F equals AUC oral divided by AUC IV. IV administration has 100% bioavailability, F equals 1, because the drug goes directly into the bloodstream, bypassing barriers. Oral drugs face absorption losses in the gut and first-pass metabolism in the liver, so only a fraction, e.g. F equals 0.3 for some drugs, reaches circulation. Want to dig into factors lowering oral bioavailability?
But why specifically this example? I don't understand it, because why do we only have in the equation oral and IV? We talked about so many methods of administration.
You're right, we covered many administration routes, so let's clarify why bioavailability often compares oral to IV in its equation. The bioavailability formula, F equals 0.3 divided by AUC oral divided by AUC IV, uses IV as the reference because IV delivery achieves 100% bioavailability. Every bit of the drug hits systemic circulation instantly, no barriers. Oral administration is compared to IV because it's the most common route, but faces major hurdles like gut absorption and first-pass liver metabolism, making its bioavailability less than 100%. Other routes, e.g., transdermal, sublingual, intramuscular, also have bioavailability, but they're less frequently standardized in the equation, since their absorption varies widely and isn't as universally studied as oral. The oral IV comparison sets a clear benchmark for how much drug actually reaches the bloodstream. Want to explore bioavailability for another route like transdermal?
Makes much sense. Okay. So let's say we have a graph now. When we see, let's say we have OCP concentration and on the y-axis, and x-axis will have time. We can see that the IV curve will drop, and then the oral curve will start going up and then again down.
You're describing a classic pharmacokinetic graph with drug concentration, y-axis, versus time, x-axis, comparing IV and oral administration. For IV, the concentration spikes instantly at its peak, 100% bioavailability, and then drops rapidly as the drug is distributed and cleared, exponential decline. For oral, the curve starts at 0, rises gradually as the drug is absorbed, peaking later due to gut-liver delays, then falls as it's metabolized and excreted. The oral peak is lower than IV due to first-pass metabolism and incomplete absorption. The area under the curve, AUC, for oral is smaller than IV, reflecting lower bioavailability. Want to unpack the graph slopes or specific drug examples?
I would like to ask you, by the end of it, why will we have a bit more drug concentration in the oral situation? Just a tiny bit more, or is this just my graph?
You're noting a scenario on your pharmacokinetic graph where the oral administration curve shows slightly higher drug concentration than IV at some point, likely toward the tail end, which can happen under specific conditions. Typically, IV starts high and drops fast due to immediate distribution and clearance, while oral rises slowly, peaks lower, and declines more gradually due to slower absorption and metabolism. If oral shows a slightly higher concentration later, it's not your graph messing up. It's likely due to differences in clearance rates or drug accumulation. For example, Oral drugs may have prolonged absorption, e.g., from the gut reservoir, or slower metabolism, causing a linger effect where concentrations stay elevated longer than IV, which clears rapidly. Another possibility is enterohepatic recycling, where oral drugs are reabsorbed after biliary excretion, boosting late phase concentration. Without specifics on the drug or graph, it's hard to pin down, but this effect is real for some drugs with unique kinetics. Want to clarify your drug or graph details for a sharper answer?
Well, that's so good. Um, so, you already mentioned, can you explain first pass pre-systemic metabolism? What does this mean? And explain it also using the intestinal tract, the hepatic and portal vein, the hepatic artery, and the systemic circulation.
First pass metabolism, or pre-systemic metabolism, is when a drug is metabolized before reaching systemic circulation, reducing the amount that hits the bloodstream. For oral drugs, after ingestion, the drug is absorbed in the intestinal tract, mostly small intestine due to large surface area. From there, it enters the portal vein, which carries blood directly to the liver. In the liver, enzymes like cytochrome P45E break down a chunk of the drug before it can exit via the hepatic vein into systemic circulation. The hepatic artery supplies oxygenated blood to the liver, but isn't the main player here. The portal vein drives the first pass effect. This process lowers bioavailability, e.g., only 30% of a drug like morphine survives. Sublingual or IV routes skip this by avoiding the gut and liver initially. Want drug examples or more on liver enzymes?
Hmm. And how would things before the systemic circulation reduce the bioavailability? Do they like hold the substance hostage? Do they say, substance, you need to stay with us? What do they, how does it happen?
Before systemic circulation, bioavailability gets reduced mainly by first pass metabolism in the gut and liver, not by holding the drug hostage, but by chemically altering or destroying it. In the intestinal tract, enzymes like CYP3A4 and gut bacteria start metabolizing the drug, breaking it into inactive forms. Then, the drug travels via the portal vein to the liver, where hepatic enzymes, cytochrome P450s, further chop it up or conjugate it for excretion. These processes turn active drug into metabolites that either stay in the liver, get dumped into bile, or never reach systemic circulation in their original form. Physical barriers like gut wall efflux pumps, e.g., P-glycoprotein, can also kick drugs back into the gut lumen, limiting absorption. So, it's less about trapping and more about transforming or ejecting the drug before it can do its job. Want to zoom in on a specific enzyme or drug?
Um, well, this is, I really enjoyed aspects of your answers today. I'm a bit bored, guys. I'll give you some insight of my feelings at the moment. Um, but I do think this is a smooth conversation. This is going good. Okay, let's talk about bioequivalence and relevance now. So, when two drugs are bioequivalent, there's no significant difference in the rate of extent, sorry, in the rate or extent of bioavailability. But this is the same conditions, under the same conditions, with the same molar dose. Explain this a bit. And let's talk a bit about relevance too. So, uh, different formulations from different companies, different batches from drugs from the same company.
I hear you're feeling a bit bored, but I'm glad you're finding our human AI podcast chat smooth. Let's keep the vibe going with bioequivalence and its relevance, keeping it tight and engaging. Bioequivalence means two drugs given at the same molar dose under identical conditions, e.g., fasting or with food, have no significant difference in the rate, how fast they're absorbed or extent, how much gets into systemic circulation of bioavailability. This is measured by comparing pharmacokinetic parameters like AUC, area under the concentration time curve, and Cmax, peak concentration. If the values are within a regulatory range, usually 80-125%, they're bioequivalent. Relevance. Bioequivalence ensures different formulations, e.g., generic versus brand, or batches from the same company, e.g., new production runs, deliver the same therapeutic effect. For instance, a generic ibuprofen from company A must match the brand name Advil in absorption speed and amount to guarantee equal pain relief. Different formulations, tablet versus capsule, or batches might vary in excipients or manufacturing, but bioequivalence testing confirms they perform the same. This matters for patient safety, cost generics are cheaper, and regulatory approval. Want to dig into how bioequivalence is tested or specific examples, or feeling something else to spice things up?
Can you repeat this? Sorry, guys, there was a deer outside my house and I went to see.
No worries about the deer distraction. Sounds like a cool moment. Let's rerun bioequivalence and relevance for the Human AI podcast, keeping it concise. Bioequivalence means two drugs, given at the same molar dose under the same conditions, e.g., with or without food, show no major difference in the rate, speed of absorption, or extent, amount absorbed of bioavailability, measured by AUC and Cmax, within 80-125% of each other. Relevance. It ensures different formulations, generic versus brand, or batches from the same company, e.g., new lots, deliver the same therapeutic effect, like a generic matching Advil for pain relief. This matters for safety, cost savings, and regulatory approval. Want to dive into testing methods, examples, or switch topics to keep it fresh?
Um, I wanna ask you. So relevance is basically that we have two companies. They sell the same substance, so everything should match in regards to if the amount they're giving.
Yeah, you got it. For the Human AI podcast, let's clarify bioequivalence relevance. When two companies sell the same drug substance, e.g., ibuprofen, at the same dose, bioequivalence ensures their formulations, like a generic versus brand, deliver nearly identical bioavailability, same rate, and amount of drug reaching systemic circulation, within 80-125% for AUC and Cmax. This guarantees both versions work equally well therapeutically, ensuring safety and efficacy despite differences in inactive ingredients or manufacturing. Want to explore how companies prove this or move elsewhere?
Yeah, how do they prove it? And then let's talk about where most drugs end up after absorption. And let's talk about drug distribution once you say that.
To prove bioequivalence, companies run studies comparing their drug, e.g., generic, to a reference, e.g., brand, in healthy volunteers, measuring bioavailability, AUC, and Cmax under identical conditions. If rate and extent of absorption fall within 80-125%, they're equivalent per regulatory standards like FDA. After absorption, most drugs enter systemic circulation via the bloodstream, distributing to tissues based on blood flow, tissue affinity, and drug properties, e.g., lipid-soluble drugs hit fatty tissues, polar drugs stay in plasma. Drug distribution is driven by factors like plasma protein binding, albumin carries most drugs, tissue perfusion, heart, liver get drugs fastest, and barriers. Blood-brain barrier limits CNS access.
Okay,
Vol-
so with drug distribution, the drug is transferred reversibly. So you need to explain to us this word reversibly in this situation from the systemic circulation into the tissues as concentrations um, in the blood. Um,
and drug
and
distribution.
from the tissues into the blood when blood concentrations decrease. So explain this decrease increase situation.
And drug distribution reversibly means drugs move back and forth between systemic circulation, blood, and tissues based on concentration gradients. After absorption, high blood concentrations drive drugs into tissues, e.g., muscles, fat, where they bind or dissolve. As blood concentrations decrease due to metabolism or excretion, drugs flow back from tissues into blood, maintaining equilibrium. This reversible shift depends on tissue affinity, protein binding, and blood flow. For example, lipid-soluble drugs slowly release from fat as blood levels drop, prolonging effects. Want to dig into specific drugs or volume of distribution?
Yeah, let's talk about how distribution occurs. So, most drugs transfer by passive diffusion. Why? So, they go across capillary walls, down a concentration gradient, into interstitial fluid until the concentration of free drug molecules in interstitium is equal to that in the plasma. Explain this process to us.
Most drugs distribute by passive diffusion because it's the simplest way to move from blood to tissues, driven by concentration gradients without energy input. After reaching systemic circulation, drugs cross capillary walls, thin, porous barriers into interstitial fluid. They flow down their gradient, high concentration in plasma to lower in tissues, until the free, unbound drug concentration in tissue matches plasma. Lipid-soluble drugs diffuse faster through capillary membranes. Polar drugs rely on gaps between cells. This equilibrium is dynamic, shifting as plasma levels drop from metabolism or excretion, pulling drugs back from tissues. Want to explore active transport or specific drug examples?
Um, so, how do drugs pass across membranes? We talked about lipid soluble drugs, we talked about passive transport, we also have facilitated diffusion, have ion channels. Tell us.
Drugs cross membranes mainly by passive diffusion, facilitated diffusion, or through ion channels depending on their properties. Lipid-soluble drugs use passive diffusion, slipping through the lipid bilayer down a concentration gradient. No energy needed. Fast for non-polar drugs. Polar or large drugs often need facilitated diffusion, where carrier proteins shuttle them across membranes. Still gradient-driven, like glucose transport. Ion channels allow small, charged drugs, e.g. electrolytes, to pass when channels open, guided by electrochemical gradients. Active transport, energy dependent, is rarer, but handles specific drugs against gradients. Most drugs favor passive diffusion due to simplicity and membrane lipid nature. Want details on a specific mechanism or drug example?
Well, no, that's so good. I want to ask about plasma protein binding. So, drugs bind to albumin in plasma. What's albumin? And we have this drug protein complex. Why is this reversible and saturable? And yeah,
Albumin is a major protein in blood plasma that carries drugs, hormones, and nutrients. Drugs bind to albumin reversibly, forming a drug-protein complex through weak bonds like hydrophobic or electrostatic interactions, allowing drugs to unbind as plasma concentrations drop. This binding acts as a reservoir, reducing free drug available to act or be metabolized, which can prolong effects or delay clearance. It's trouble because high binding, e.g., 99% for warfarin, means a little free drug, so small changes, like competition with another drug, can spike free levels, risking toxicity. Low albumin, e.g., liver disease, also increases free drug, amplifying effects. Want to dive into specific drugs or binding competition?
um, I wanna ask you about protein bound drugs like warfarin, phenytoin, aspirin, thyroxine, ibuprofen, heparin, furosemide.
Highly protein-bound drugs like warfarin, phenytoin, aspirin, thyroxine, ibuprofen, heparin, and furosemide bind tightly to plasma proteins, mainly albumin, 90% plus binding, leaving little free drug to act. Warfarin, 99% bound, controls clotting. Phenytoin, 90%, treats seizures. Aspirin, 80-90%, reduces pain. Thyroxine, 99.97%, regulates metabolism. Ibuprofen, 99%, fights inflammation. Heparin, 95%, promotes urination. Furosemide, 95%, promotes urination. High binding limits free drug, prolonging effects and slowing clearance. Trouble comes when drugs compete for binding sites, e.g., warfarin plus ibuprofen, displacing each other, spiking free levels and risking toxicity, e.g., bleeding with warfarin. Low albumin, e.g., in kidney disease, also raises free drug, amplifying effects. Want specifics on one drug or competition effects?
That's so good. Why don't we talk about body fluid compartments, so intracellular and extracellular fluid volume, and then explain to me how we break down extracellular to interstitial fluid volume and plasma volume?
Body fluid compartments are split into intracellular fluid, ICF, most 60% of total body water, inside cells, and extracellular fluid, ECF, most 40%, outside cells. ECF breaks down into interstitial fluid, most 75% of ECF, fluid between cells and tissues, and plasma, 25% of ECF, liquid part of blood. ICF holds about 25 liters in an average adult. ECF around 15 liters, 11 liters interstitial, 4 liters plasma. Drugs distribute across these based on solubility and binding. Lipid-soluble drugs favor ICF. Polar drugs stay in ECF, mostly plasma, if protein bound. Want to connect this to drug distribution or dive into measurement methods?
Um, well, what other factors affect drug distribution? Like the physical chemical properties, lipid solubility, water solubility. Tell us about size, drug protein binding, pH.
Drug distribution is shaped by physicochemical properties and physiological factors. Lipid solubility lets drugs cross membranes easily, favoring tissue penetration, e.g., fat for diazepam. Water solubility keeps drugs in plasma or extracellular fluid, e.g., mannitol. Molecular size matters. Small drugs, e.g., lithium, diffuse freely. Large ones, e.g., heparin, are restricted to plasma. Drug protein binding, mainly to albumin, limits free drug. Highly bound drugs, e.g., warfarin, 99% stay in plasma, reducing tissue distribution. pH affects ionization. Non-ionized drugs, lipid soluble, cross membranes better. Ionized ones, water soluble, stay in plasma or urine. Blood flow also drives distribution. Well-perfused organs, heart, liver, get drugs fastest. Want to zoom in on one factor or a drug example?
I want to ask you about apparent volume of distribution. So, this is like a concept that tries to predict how extensively a drug is distributed through the body. So, how do we do this?
The apparent volume of distribution, VD, is a theoretical volume that estimates how widely a drug spreads in the body, calculated as VD, total drug amount in body, divided by plasma concentration. After giving a dose, e.g., IV, measure plasma concentration. A low VD, e.g., 5 liters, like warfarin, means the drug stays in plasma, likely protein bound. A high VD, e.g., 500 liters, like chloroquine, indicates extensive tissue distribution, often lipid-soluble drugs. It's not a real volume, but a ratio reflecting tissue versus plasma partitioning. Factors like lipid solubility, protein binding, and tissue affinity affect it. Want to explore VD for a specific drug or its
No,
clinical use?
no, it's okay, but just to touch from before. So, plasma volume is like 20% of extracellular, and then interstitial is most of it. I don't get why, and why does the VD go to interstitial?
You're circling back to body fluid compartments and wondering why the volume of distribution, VD, often relates to interstitial fluid. So let's clarify tightly. Extracellular fluid, ECF is about 40% of body water. VD, e.g., warfarin, plus 500 liters. Split into plasma, most 25%, VD, 4 liters, and interstitial fluid, 75%, 11 liters, which bathes tissues between cells. Interstitial fluid is the bulk of ECF because it fills spaces around cells across organs, unlike plasma, which is confined to blood vessels. VD, the apparent volume of distribution, shows how a drug spreads beyond plasma. If a drug's VD is around 15 liters, close to ECF, it likely distributes into interstitial fluid, but not much into cells, e.g., polar drugs like gentamicin. Interstitial fluid dominates ECF volume, so drugs that leave plasma but don't easily cross cell membranes due to low lipid solubility end up here, inflating VD toward ECF's range. Lipid-soluble drugs, e.g. diazepam, go further into intracellular fluid, pushing VD much higher, hundreds of liters. Protein-bound drugs, e.g. warfarin,
can I
stick
ask
to
a
plasma,
question?
keeping VD low,
If you
most
can,
5
let
liters.
me ask one. Thank you. So with volume of distribution, do we have the dose?
Go for it. What's your question for the Human AI podcast? I'm all ears. Or rather, all text.
Fuck off. So, with volume distribution, remember, please answer in smaller answers in general. So, is it dose over plasma concentration?
Yes. Volume of distribution, VD, is calculated as dose divided by plasma concentration. VD equals sign 2, dose divided by plasma concentration. VD equals sign 2 divided by plasma concentration. Want more on what this means for drug spread?
Well, why? So if the dose is 1 gram,
if the dose is 1 gram, VD equals sign 2 divided by plasma concentration, e.g., 0.1 gram p liter gives VD equals sign 10. This works because VD assumes the drug instantly distributes. Dividing dose by measured plasma concentration estimates how much volume the drug occupies, reflecting tissue versus plasma spread.
so okay. So if I have a large VD, then wait.
A large
Okay, so let's say. Okay, let's think of a few examples. I give a gram of a drug. I see that it has, let's say, wait, let's think of some numbers. A gram of a drug A, 1 gram. I can see it's spread 0.5 grams per liter, or 0.1, let's say. So 1 over 1 over 10, 10. So we have 10 per liter, whatever. And then let's say we
let's
have,
clarify your example for the human.
let's say we have drug B. This time we have 1 gram, but we have 0.2 grams per liter. So it's 20. So if it's 20,
For drug B, you give 1 gram.
so if it's 20 now, we have a higher. So we have a higher concentration in the blood. So if I have a larger VD, will I need to administer more or less of that thing?
If drug B has a VD, a larger VD, like 20 liters, means the drug spreads widely into tissues. Less stays in blood compared to, say, a VD of 10 liters. To achieve the same therapeutic plasma concentration, you'd need to administer more drug for a higher VD because much of it leaves the blood for tissues. For example, if drug A, VD 10 liters, needs 0.2 grams per liter, drug B, VD 20 liter, requires a bigger dose to hit that same level. Want to run specific
No,
numbers or clarify further?
I don't get why drugs that have a large VD will need to be administered in larger volumes to achieve a target concentration in the plasma.
A large VD means a drug spreads extensively into tissues, leaving less in the plasma. To hit a target plasma concentration, you need a bigger dose because much of the drug is soaked up by tissues, reducing what's circulating. For example, if drug B has a VD of 20 liters and you want 0.2 grams per liter in plasma, you need 4 grams total. 20 liters times 0.2 grams per liter, versus only 2 grams for a drug with VD of 10 liter. More tissue distribution demands more drug. Want a visual analogy or
Well, I'm a bit
specific drug
confused.
example?
I'm a bit confused because so what do we mean if a drug has low VD? So let's say warfarin has a VD lower than 10 liters. Is this true for warfarin all the time? Is this like a property of warfarin? Uh,
A low VD, like warfarin's micro, 8 liters, means the drug stays mostly in plasma, with minimal tissue distribution, often due to high plasma protein binding, 99% to albumin. This is a consistent property of warfarin across patients, as its chemical structure and binding affinity don't change. However, VD can vary slightly between individuals due to differences in body weight, albumin levels, or disease states, e.g., liver issues lowering albumin. For warfarin, low VD is typical, so less drug is needed to hit therapeutic plasma levels compared to high VD drugs. Want to compare warfarin to a high VD drug or dig into why it binds so tightly?
you need to explain to me. It just seems to me like volume of distribution. It sounds to me like if you have a high volume of distribution, it means that this is a good thing. Or is it bad because we don't want to distribute a drug to too many places? We only want it in specific areas.
Volume of distribution VD isn't inherently good or bad. It depends on the drug's purpose. A high VD, e.g., grams 40 liters, like digoxin, means the drug spreads widely into tissues, which is great if you need it in specific organs, e.g., digoxin for heart tissue, but bad if it causes off-target effects or needs high doses to maintain plasma levels. A low VD, e.g., warfarin micro 8 liters, keeps the drug in plasma, ideal for targeting blood-related effects like clotting, but less effective for tissue-specific actions. High VD can complicate dosing since more drug gets lost to tissues, while low VD makes plasma levels easier to control.
Okay.
Want an example of when
But
higher...
a low volume of distribution, don't we have a risk that the drug will be distributed in the wrong parts?
A low VD, like warfarin's micro 8 liters, means the drug stays mostly in plasma due to high protein binding or low tissue affinity,
So we're talking
reducing the
about
risk
the
of it spreading to
So we're
unintended
talking.
tissues. This is generally a
Excuse me.
plus for
Could I
drugs
ask you a
targeting
question?
blood or...
Okay. So we're talking specifically about the distribution to tissues. So if we have low distribution, it means low that we have a good amount in the blood.
Yep, exactly.
And is there
A
a
low
difference?
volume...
Is there a difference between blood and plasma?
Yes, there's a difference between blood and plasma. Blood is the whole fluid in your vessels, made up of plasma, 550%, red blood cells, white blood cells, and platelets. Plasma is the liquid part of blood, mostly water, carrying proteins like albumin, nutrients, and drugs. In pharmacokinetics, drug concentration is measured in plasma, not whole blood,
Got it.
because plasma reflects the
Okay.
free and
Thank you so
protein-bound
much
drug
for letting me
available
know
to
about
distribute.
this. Okay. So, guys, I hope you find this video informative and enjoyable. I can't wait to see you at the next episode. Bye bye.